Good morning, everyone. I'm Sakshi Dhamiwal from AIMS Bhopal, and today I will be providing a brief overview of a case involving a classic presentation of herpes zoster ophthalmicus that unfortunately progressed into orbital apex. So herpes zoster ophthalmicus stems from the reactivation of VZV virus, and it can advance into orbital apex under certain conditions. So amongst documented 20 cases till now, most of them were either above 60 years old or immunocompromised patients. So I present such a case of healthy 44-year-old male which presented with complaints of 3-week history of vascular rash, 1-week duration of vision loss, and droopy lid for the past 3 days. On further evaluating the history of the patient had a history of systemic steroids with suboptimal antiviral uses after rash development, and within a week of which he complained of significant decline in visual acuity and deterioration in his extraocular movements. On presenting to us, the patient had inaccurate PR with severe ptosis, with limited grade -4 movement restriction in all his gazes. Anterior segment examination revealed complete corneal melt. Other details were not much appreciable. B-scan revealed vitritis and features of acute retinal necrosis. Further, MRI revealed hyperintensities along optic nerve sheath and extraocular muscles, which confirmed the orbital involvement. So the patient was managed with IV acyclovir in a doses of 500 milligram TDS along with aqueous suppressants and cycloplegics. So additionally, 1 week later, he was started on IV methylpred pulse therapy. Subsequently, maintenance dose of both oral steroids and acyclovir antivirals was given. In follow-up in 3 weeks, he had a significant improvement in his extraocular movements and resolution of signs on B-scan and MRI. However, his PR was still inaccurate. So amongst 20 cases documented till now, most of them were either above 60 years old or immunocompromised. And the youngest case recorded till now was a HIV positive patient. In contrast to that, my case had negative serology with almost all normal blood investigation. But he had a history of systemic steroid abuse with inadequate antiviral coverage. So my case might be the only immunocompetent case recorded till now in my knowledge, complicated to such a severity. So the question remains, is it a sign of evolving trend or is it due to steroid? So my take-home message from this case would be that always ensure adequate and timely initiation of systemic antivirals, preferably within 72 hours from the rash development, and never to use systemic steroids in early stages of SZO or when it is not indicated. And in the end, I would say always assess optic nerve, extraocular muscle, and any orbital, extraorbital involvement in every follow-up. And I believe that way we can provide the best for our patients. Thank you so much.
Thank you, Dr. Sakshi. That was an interesting case. So your patient was not immunocompromised?
No, ma'am.
He was not diabetic?
No, ma'am.
He did not have any other...
Ma'am, he has a low level of HDL. Other than that, nothing. All blood investigations was within normal limits.
And how much was the duration of steroid use in your patient?
We started after 1 week of antiviral coverage. We started after 1 week antiviral, and we first give IV methylprednisolone pulse therapy, and then we tapered him like within a week of 5 weeks duration.
And prior to that, he already had some steroid use?
He had a history of systemic steroids from outside uses, ma'am.
For how many days?
For about 1 week, ma'am.
Okay. So do you think that is the contributing factor? How do you account?
Ma'am, if we are not controlling the infection and prior to that we are giving steroids, so that could be the cause of spreading of the inflammation to posterior segment and to the orbit also. So I believe that it could be the cause, ma'am.
So do you have any other differential in this kind of scenario? Because we know HZO are generally, the patient might not have any obvious immunocompromised trait on your investigation, but those are very small set of investigation we have done. So in this kind of scenario where we know that it's a young patient, relatively young, has herpes, Do you think of any other differential which could be the cause of this ophthalmoplegia?
Ma'am, as the patient has like anterior segment corneal melt, so but due to presence of vesicular development in dermatomal distribution, and it was like confirmatory that it is herpes zoster, and following that, if we rule out like Tolosa Hunt syndrome, they all respond to systemic antibiotics very well. And plus, if we consider idiopathic orbital inflammatory disease, they respond to steroids very well. So they all are ruled out in my case. I could not find another cause, ma'am.
If you go back to the MRI picture, the patient had some thickening of the extraocular muscle and there was some inflammation of the sinus mucosa on the same side. But there was ethmoidal sinusitis.
Yes, ma'am.
So do you have anything in mind if you have those kind of patient? Could it be something else causing an orbital apex?
Paranasal sinuses were within normal limit. There was no...
If you look at the MRI scan, there was some thickening of the sinus mucosa on the same side.
Ma'am, it could be later on secondary to herpes zoster, ma'am. According.
So basically what we are trying to point out here that the patient has a disease which is more common in the immunocompromised state. You are seeing an ophthalmoplegia, like an orbital apex syndrome, which you know if there is an associated sinus involvement with an orbital apex syndrome, most often our commonest differential comes again and fungal granuloma, mucormycosis or other things. Sometimes the presentation can be very subtle, especially with extraocular muscle thickening and things like that. So that's the differential we need to keep in mind because we are again giving steroid to the patient. So we have to be really, if you plan to publish this case or send it somewhere, you have to be very sure that it's herpes only which is causing this and not something else.
Ma'am, on lumbar puncture, his CSF was also suggestive of like from neurological side. Yes, ma'am.
Why did you do a CSF tap?
Ma'am, CSF temp IgM antibodies we looked for, ma'am.
Was there anything to suggest any CNS involvement?
Ma'am, according to, we confirmed the neurologist also, they also said that it's more likely of a picture of herpes zoster ophthalmicus only, according to them. And
so, but is this a protocol to do a CSF tap in all orbital apex syndrome? How do you?
Yes, ma'am.
Do you do a CSF tap in orbital apex syndrome? That's the question.
Ma'am, we usually don't do, ma'am, but when we send the patient to a neurologist, he prefers to do a lumbar puncture and CSF investigations. So, because because patient is having neurological manifestations and the involvement of all cranial nerves, 2nd, 3rd, 4th, 6th. So, so there are highly chance that from the
So since you mentioned this 2nd, 3rd, 4th, 6th, if all the cranial nerves are involved, what is the likelihood of the site of involvement? Is it the spine or somewhere else? Where do all these nerves meet? Whenever you have involvement of all these nerves together, what do you really suspect?
Ma'am, orbital apex and the we can cavernous sinus also.
So you don't need to do a lumbar puncture in all these patients, one thing.
Yes,
the other question is that I don't think any neurologist would go ahead and do a lumbar puncture for this kind of a presentation. And the other thing that was it a first attack or what, did you look for any signs of similar episode in the past?
He had no prior similar episodes, ma'am.
And what was the entire duration of the illness from start to the end?
Ma'am, he presented to us after 2 weeks.
But what was the course of illness, the entire thing?
5 weeks.
5 weeks. So what is your take-home message that within 5 weeks such a massive deterioration has occurred? So do you suggest that, what is your take-home message for the audience today?
Ma'am, as the patient presented to us on 2 weeks and prior to that he was on systemic steroids. So we should not give systemic steroids before like confirming what the basis of inflammation he is having. So that is the message. Plus local practitioners tend to use systemic steroids.
So what came first, the vesicles, the corneal involvement? What came first, or the
vesicles, ma'am.
The vesicles. So that should be your take-home message, that you should target that first and not jump onto steroids for everything.
Yes,
and keep a close watch for ocular manifestation. That should be your message. Thank you so much.
Thank you, ma'am.
Thank you.